See folks entering the call. This is perfect. Thank you, everybody, for your patience. We're delighted to get started. Welcome. My name is Helen Craigie, and I want to welcome you to the Convergence Health Workforce Wellbeing and Violence Prevention Improvement Series. So today is our final session, session 5. Yes, it can happen here. Lessons learned in violence prevention from a critical access hospital. So today's going to be a fantastic peer learning opportunity. We are very excited to have you here and to be joined by our presenter. But before I start with introducing him, I'd like to do a little bit of housekeeping. Just as a reminder for these webinars, we encourage you to use the chat box for asking questions throughout the call, throughout the meeting. But our speaker will address questions at the end, and we'll do a Q&A session at the end. And let's just go ahead and get started. So to introduce myself, my name is Helen Craigie, and I'm your host for this series. I've been in the quality improvement patient safety space for about 10 years now, working on national quality improvement patient safety initiatives for CDC grants, AHRQ grants, and currently on a CMS HQIC grant, working for with Convergence Health team. So very excited to have you here today. And I'm just learning so much from this series. As a bit of context for this series and for our speaker today, I just wanted to chat with you about some of the growing challenges that our U.S. healthcare workforce is facing in workforce well-being and violence prevention. So OSHA, the Occupational Safety and Health Administration, estimates that nearly 75% of the 25,000 workplace assaults reported annually happen in healthcare settings. So this is a startling fact, and we know that it is actually underrepresentative of the actual incidents. So underreporting of workforce violence is a key issue. And they think that that's mainly due to the negative view of effectiveness of policies for managing violence, and then also dismissing it as part of the job, unfortunately. So workplace violence is seen as a leading cause of job dissatisfaction among providers and linked to burnout, absenteeism, and reduced worker retention. As we know, COVID-19 exposed and amplified a lot of the underlying staffing issues, including an absence of trust among team members, lack of adequate time for patient and self-care, and a lack of psychological safety in the healthcare setting. Violence in the workplace can lead to negative psychological consequences, including low self-esteem, increased anxiety, and stress. So in recognition of this, the Convergence Health team has put together this workforce well-being and violence prevention improvement series. And we've really taken a broad approach, and you've heard from our speakers over these past few weeks. And today we are delighted to bring Dirk Monson from Francis Mahone Deaconess Hospital in Montana for his talk on lessons learned in violence prevention from a critical access hospital. So without further ado, Dirk, I'm going to turn it over to you to introduce Dirk briefly. He's the Director of Facility Services at Francis Mahone Deaconess Hospital in Glasgow, Montana. And as we have for our previous speakers, we're going to ask Dirk to start his conversation today with all of you, talking about why this topic of workforce well-being and violence prevention is important to him personally. Dirk, we're going to ask you why this topic is important to all of us attending here today, and then also in the larger context of now. So, Dirk, I hand it over to you.
All right. Well, thank you, Helen. Thank you for having me tell our story today. I am Dirk Monson, Director of Facility Services. It's Francis Mahone Deaconess Hospital in Glasgow, Montana. We're in the northeastern corner of Montana. And you can all see on my bio there, I didn't know all along that I was going to be in a healthcare facility. That means that because with critical access hospitals in rural areas, a lot of times the folks that are in the non-critical roles don't necessarily have a spelled out background that got them into healthcare. With a lot of the clinical folks, it's that way, but not so much with some of us in the support services. Yet here we are managing these services within the hospital. And I'm a lifelong resident of Northeast Montana, and didn't get into a little bit more as we move along, but didn't realize until actually I was about 30 years old in Northeast Montana.
Yeah, seriously, so we've lost Dirk's audio.
Let's give it just a moment and see if we can regain his audio.
Geez, folks, just hang on for 1 second.
Yeah, apologies, folks.
Able to dial back in. Just hang on with us 1 second.
This is the wonderful internet age that we're in with Zoom issues all the time. It is absolutely not the fault of anyone, but appreciate your patience, folks. If we are not able to get him back in via audio within another minute or so, we may end up doing an alternate way of getting this information to you, because it's a story that I want to make sure that folks are able to hear.
That's a great question.
Yeah.
Jennifer is asking, where are folks from today? Oh,
I'm back, Helen.
Okay.
I apologize.
welcome.
Gonna fight us, hopefully not the whole way.
Okay, great. Thank you.
Happy to have you back.
So, yeah, so the reason workforce, well-being and workforce violence prevention, for me as a safety officer at Francis Mahon Deaconess Hospital, it is really one of my duties to make sure that people are safe, that we're taking the proper measures to make sure people are safe, not just our employees, but our patients and visitors as well. And of course, all of us here, if we're participating in this webinar, we must have a role or a stake in workplace violence prevention and workforce well-being in our facilities in which we work. And of course, we're all aware of the challenges of recruitment and retention in healthcare, and certainly a lack of feeling secure and safe is going to exacerbate that problem for all of us in healthcare. And really, it goes beyond just healthcare. We have to live in a safe society. People can't live in fear. Certainly going to affect quality of life and quality of employment if people don't feel comfortable in the places that they work, recreate, and right down to the grocery store. So I think in the climate in the country right now, everybody should be able to relate to that. So a little bit about Glasgow and Francis Mahon Deaconess Hospital. I mentioned we're in the northeastern corner of Montana, very rural. 2 weeks ago, when Karen Garvey presented from Parkland Health in the Dallas area, she mentioned that they care for a county jail population of 6,000 to 7,000 inmates. 7,000 is roughly the population of our county. And so I found that statistic just kind of unbelievable for a rural person to really grasp my head around. In the cities, the kind of population that those people serve in healthcare. So in 2018, a Washington Post article came out, and they had used a tool that the Malaria Atlas program had used to measure distances to services as it related to healthcare, particularly malaria. Well, the Washington Post had something else in mind. They just wanted to find out really truly what are some of the most remote areas in the country, and Glasgow was determined to be the literal middle of nowhere. And that's in that we are a town of over 1,000 people, and then measuring the distance to services, such as health care, and a higher level of care that you could receive here. And just to put it into simple terms, we're 140 miles from the nearest Walmart. So we really are out in the middle of nowhere. That being said, I am extremely proud of Francis Marion Deaconess Hospital and the level of services that we provide our community, not just in Glasgow, but in Northeast Montana, with a full suite of general and orthopedic surgery, as well as physical therapy, occupational therapy, cardiac rehab. So we really are kind of a little mini regional healthcare facility for our area. So with that, we are extremely rural, and of course in rural areas, people often think that, that can't happen here. As the title suggests, that can happen here. We consider ourselves a very safe community. However, this organization, Francis Marion Deaconess Hospital, back in January of 2009, had an extremely random act of violence take place where a kind of a reclusive guy that was very little known in town set up outside, and as one of our EMTs was leaving our ambulance barn, he shot and killed the EMT. He shot at the responders that rushed out to help her. Got in a gunfight essentially with police, was wounded, fled on foot on the river bottom. This happened in daylight in January, so it was around 4 p.m. And by the time law enforcement ultimately tracked the man down, had an encounter with him, and ended up killing him on the river bottom southwest of the hospital. As you can imagine, that was an extremely tragic event for our community. It was extremely tragic for FMDH and those employees that were here during the time. Those wounds, though healed over, they are still there. It's very evident to me as we discuss safety and security with our folks. Anytime that event gets brought up, those that were here that night, you can see it on their face. Have a lot of compassion for those folks. And that of course, was 2009. Then 2018, we did have a suicide take place in a vehicle in our parking lot. So again, this was something a little more isolated. This wasn't an act of violence against healthcare workers, but certainly, disconcerting as well. And then that brings us to March 29th of 2023, which we're going to talk about today. And I'm going to kind of tell the story from my perspective as it happened that day, and then follow up with our response to that, and all that was involved in the follow-up with this experience. So, Helen, if you'll advance the slide, please. So, and these slides, these photographs in the slides are the areas of our facility and our campus in which these events happen. Interestingly, We have a video surveillance camera system, and we had upgraded in 2022 from 16 cameras up to 40 cameras, but it was kind of a fine line. We wanted to have good coverage of our public areas, yet we're still the kind of facility and the kind of community that very open, very friendly, and we don't want to monitor everything that goes on in our facility, just that's needed to provide an extra level of security. Fortunately, we had done that. So on March 29th of 2023, of course, it was near the end of the COVID pandemic, but it was still kind of a thing. After lunch, I had gotten back to work. One of my common practices after lunch most days is to review the cameras. We don't have 24/7 security. We don't have a security guard with the cameras up and 24 hours a day or anything. But I review a couple times a day, and I just happened to pull up the camera to this south wing entrance and see a jailer and an inmate arriving. Our physical therapy department is on this wing of the hospital. The inmate was in the striped jumpsuit, was using a walker, and was not handcuffed or shackled, which was unusual, but it's very much not unusual for our facility to treat inmates, patients from the county jail. County jail here, Valley County Jail averages around 20 inmates at any given time. And it wasn't uncommon for maybe once a week you would see a jailer with an inmate in our facility for treatment, generally in a primary care clinic, but could have been in the lab. In this case, it was physical therapy. So anyway, I took note of that, but it wasn't unusual. I trusted the judgment of the jailer as to how he would treat his inmate. Next slide, please. So it was a physical therapy appointment. This is at one of the treatment rooms. Inside this treatment room, this inmate had on his person an improvised weapon that he had constructed prior to this visit. And on that note, prior to this visit, so what they had been doing is he had previous PT visits. When one visit was over, in front of the inmate, they scheduled the next PT visit, which we later learned was a mistake on our part. It was a mistake on the department on the law enforcement as well. There should not have been knowledge of the next visit, as this was part of a plan that this inmate had to make his escape plan, essentially. So he had come with a weapon. He had come with clothing that he had gotten while he was doing laundry in the jail underneath his jumpsuit, which hadn't been checked. During the appointment, he used the improvised weapon, held it up to the physical therapist, who was a female, and used that leverage to get the jailer on the floor and had the physical therapist tie him up using the leads from one of the treatment machines. Then, to upgrade his weapon, they requested that the receptionist bring a scissor, not knowing why, and not being so unusual. She did bring a scissor, and that was his new weapon that he was holding to the physical therapist. Then, with the jailer tied up and the physical therapist held up with now a scissor, left the treatment room, and now the other two male physical therapists, the director and the other therapist, were aware of what was going on, but his instructions were to stay back. They complied with that. If you go to the next slide, please. They came out of the physical therapy department and down this corridor to this exit, which is the one where they came in. And the director of PT and the other therapist kind of followed. By now they were fully aware of what was happening. The inmate led the jailer and the physical therapist out of the facility and into the county jail vehicle. While that was happening, the PT director called 911 and was kind of running up and down the hallway trying to keep an eye on the vehicle as it drove up behind our facility. If you go to the next slide, please. So the inmate locked the jailer in the back of that county jail transport vehicle, and they switched vehicles and got into the physical therapist vehicle. So now the inmate has his scissor up to the side and or neck of the physical therapist as they get into her vehicle. 911 has been called. Law enforcement is on the way. Next slide, please. So this is kind of the opposite, looking the opposite direction of the previous slide. This is the exit to that parking lot, or one of the exits to that parking lot. The physical therapist is driving down this on top of a levee, so there's really nowhere to go. You can't drive to the right or the left until you get to the intersection. Just as the physical therapist and the inmate in her vehicle got to that intersection there and were going to turn right and go into the city of Glasgow, the deputies showed up just in the nick of time before this may have turned into something like a high-speed chase or something like that. At that point, the physical therapist made a choice for herself that she could get out of the vehicle. She did bail out of the vehicle, opened the door, and bailed out. The inmate came out with her and essentially on top of her. They scuffled on the ground. As I had heard later from her mother-in-law, she had a handful of hair and was trying to, hit his head against the asphalt. She was fighting for her life because he still did have a weapon and had expressed his intent to harm her should she not follow his demands. While they were struggling, two deputies ran up. There was snow at the time. They ran through snow drifts on the edge of that levee. And as the physical therapist and inmate were struggling on the ground, a deputy shot the inmate at point blank in the head. So, I mean, very, very traumatic for all involved. When the physical therapy director was running up and down the hallway, it got the attention of the folks in a nursing meeting that was taking place in one of our meeting rooms. They ran out of the room to see what was going on. He let them know, and I'm gonna stop here. And for those that are in critical access hospitals, they'll probably understand this a little more because we are small communities, small towns. Our hospitals are large employers. So the two nurses that came out of that meeting, one was our director of nursing and one was our director of surgical services. The director of surgical services is the sister of the director of physical therapy that was going up and down the hallways trying to keep track of the situation. She's also the wife of the other physical therapist that was involved with this. At the same time, as this was happening, my wife, who is an aide in cardiac rehab, was just around the corner from the entrance where the inmate, the jailer, and the physical therapist left the building. So point being that when you're in a small hospital like this, in a small community, and that hospital is a large employer, that everybody in this facility, all of our employees are kind of a family, but literally we have a lot of husband and wife, parent and child employees in the facility. And in this case, that was certainly the case with those most directly involved with this. They weren't just co-workers, they were brothers and sisters and husbands and wives. So with that said, those two nurses came out and provided CPR and first aid to the inmate until the ambulance showed up. The ambulance barn is a block away, so it didn't take long for the call to them to get to the incident. And so now to kind of step back, everything I've told you to this point was learned kind of after the fact, because this happened, in physical therapy. There was no knowledge in the rest of the facility as this was going on. It was at this point when EMS was paged for this by law enforcement that I became aware that anything was going on. I was in the cafeteria with a couple of the maintenance guys who happened to be EMTs, and they received a page, and they said that an inmate was just shot in our parking lot. And of course, normally that would just trigger an instant reaction from me, like, what the heck is going on? But since I knew that the inmate was in our facility for treatment, that didn't surprise me. My assumption was that, well, maybe he tried to run, My assumption was definitely not that there was essentially a kidnapping that had taken place. So, of course, I immediately went down to that south wing and to the vicinity, and the inmate was into our emergency department by that time. So I went and talked to law enforcement, to the deputy that had shot the inmate, and just let him know that we had camera footage, and anything he needed from me, please let me know. I went back in the facility, and this is one of my lessons learned, and this showed up in our after action report as we reviewed this. At that point, I should have made the announcement to the facility overhead that we had an incident, that there was no further danger. But I was so focused on reviewing the footage and getting the information for law enforcement that I didn't do that. That announcement did come a little bit later from administration, and really I had learned wouldn't have been necessary had I gotten the message out sooner. So that was one of my big takeaways from this, was when you have an incident, those people that are in the know of what has happened, share as much information as you can, absolutely as soon as you can, with your organization, so everybody knows where we are in the incident. So next slide, please. So that was the first thing that I did. Of course, law enforcement, we had all the law enforcement in town show up within minutes. One of the officers that I know personally came down to my office with me immediately after this had taken place, and after the physical therapist and the receptionist were being attended to. We came down and immediately went to reviewing the video camera footage from the hallway outside of physical therapy, and it was very surreal. And I had to look at at the trio coming out of physical therapy. I looked at it 3 times before I realized that this was the inmate, the physical therapist, and the jailer, because since I had seen the inmate go in with the jumpsuit on and using a walker, I did not expect to see somebody coming out in a dark t-shirt, sweatpants with a hat on that happened to have been the jailer's hat. And I had to rewind it several times, and I realized, well, that's them. And as I told you, the story I told you up to this point, I had only learned after the fact. That's when it really became clear that this was a hostage situation, that he was holding a weapon up to our physical therapist, and had the jailer tied up and was leaving the facility. Then I continued to work with law enforcement, our local law enforcement, for quite some time after that, as we put together the string of events that had just unfolded to get a clear picture of what had happened. Once that we had done that, then of course he went off with the rest of law enforcement to really debrief on the situation and continue to investigate. As I said, administration had made the overhead page, and we locked down the facility briefly. And then once all the information was shared that there was no more threat, we reversed that lockdown. And then shortly after, we had our hospital incident command meeting, where really, since the incident was essentially over, I mean, and like I say, it was just really a matter of minutes that the whole thing lasted. Our focus was really on the victims and some messaging to the public, especially on care for the victims and follow-up, mental health follow-up with those directly involved. So we had our incident command meeting and made those arrangements, made those plans. It was late that evening. Of course, we're out here in eastern Montana. Anytime there's an officer involved shooting with law enforcement in Montana, the State Department of Criminal Investigation are the ones that are going to investigate that. But they're in Helena, Montana, which is about 5.5 hours away. So it wasn't until later that evening that the Department of Criminal Investigation investigators showed up. They met with hospital staff here and kind of got a rundown of what had transpired. They met with law enforcement, who investigated long into the night. We had surrounding counties send law enforcement to help out with this, and all our local jurisdictions as well. Next slide, please. The following morning, of course, the word is out now, and now the follow-up has really started. We got a call from our insurance provider just wanting an update on what had happened. It did take till afternoon to have the critical incident stress debrief with those that were directly involved. The team came out of Plentywood, Montana, which is 140 miles away. But they did have their debrief, which was very helpful for those that were directly involved. It wasn't until the following morning that we had the hot wash for the rest of those in the facility that were involved in any way with the incident. Held that hot wash and got a lot of good information that ended up in our after action report and improvement plan. And then also on that day, the 31st, 2 days following, we did have a counselor from our employee assistance program on site, and was there for anybody that needed to come and visit with that counselor. Next slide, please. So, that was the incident, the immediate follow-up from the incident. Then, as you can see, the process that followed was very lengthy and very involved. Right off the bat, we self-reported to the Joint Commission because as this did cause a death of a patient at FMDH, it does qualify under their definition of a sentinel event. we self-reported to them. They had us, it was quite an interesting process. It was quite a well-streamlined process. I was not looking forward to the process of reporting this, but it was very well streamlined. The Joint Commission has done a wonderful job of making this arduous process really as straightforward as possible. We completed a root cause analysis for them, and then from that came up with our measures for improvement, and then followed that up with periodic measures of success to show them what we had done based on that root cause analysis to prevent this sort of thing from happening again. So that was a very interesting process. It was very nice working with the representative from the Joint Commission and our risk manager through that process. We held periodic meetings with the sheriff, who oversees the county jail and all the inmates as they come over. But not only that, any patients that are in custody of law enforcement, we had the chief police involved in some of those meetings as well, to discuss how we're going to move forward. Because as of the day of this incident, we suspended all but emergency treatment of any inmates from the county jail until we could revise the processes that failed. So we had those meetings, and then in-house, we formed a committee. I believe it had 7 members. It was a comprehensive committee from nursing, from patient accounting, to emergency department, and our process improvement folks. And we met 7 times during the remainder of 2023 to comprehensively review how and come up with our new policies and procedures for receiving inmates and any patients in custody. And this kind of, it was really kind of a can of worms, because we ended up answering a whole lot of questions kind of been lingering around, but hadn't really become in our policy procedures as they relate to treatment of inmates, as far as physical treatment, as far as clinical treatment, and as far as the billing for those patients as well. It all got a thorough look, and we updated many of those. Following this, August of 2023, we hired a security consultant to come and do a comprehensive assessment of our facility and our security measures. That was an extremely valuable process. The gentleman came from the Seattle area, and he did his physical assessment. He was here in the daytime. He came late.
I'm sorry, Dirk, your audio keeps cutting out.
Okay. Is it any better?
It's a little bit better now. I can.
Okay.
You're good.
Yeah, I was speaking to the security assessment. Very interesting process. One of the big takeaways from that was this gentleman's perception that we probably are a little complacent because we are a small community, and we did believe that things such as this incident can't or won't happen here. And that was in the first paragraph of his assessment, is that it is a very friendly, very open environment, very nice community. The people are very nice, but probably a little complacent when it comes to safety and security, because you know, we are all those things that I had just mentioned. So and beyond that, he had many physical security recommendations, many of which we have implemented, many of which we are still working on. We increased the number of credentialed access applications to different areas of the hospital. We've changed some policies and procedures. We've fortified our exterior entrances, and we are in the works to fortify our nurses station at the emergency entrance so that, you know, we really have a refuge for those folks that are here, especially after hours. Should somebody gain entrance to the building that means to do harm. As well, we made a commitment as part of that security assessment to provide training. We have completed the active violence and emergency response training, or AVERT training, with the majority of our staff, offered it to everybody that wanted to take it. And like I say, we got most people through that course. Excellent course. I would recommend it to anyone. The first comment I had from an employee after that course, when I asked her how it went, she just said it was really interesting. It made me think of what I might do in these situations. And it truly did. It goes through some real life active shooter type situations and how to respond to that, and gives you ideas so that should you ever be in that situation, you have thought about it and you can make a plan of action. And I followed up after that AVERT training by going around to each department in the hospital and having very specific security-related discussions with folks and giving them scenarios and saying, right now, here's the scenario. If we got an overhead page that there was a shooter at the main entrance in your department right here, right now, what would you do? And we talk through those and then change the scenario to now something's happening right outside of your department. Now, what would your reaction be? How would we respond? And very, very interesting. Folks found it very useful to at least have put some thought into these things so that should the day come, if they ever have to use them, they've put that thought in and will be able to act. And it was interesting for me to see the different responses based on your department, and primarily based on the clinical areas. The response is much different from somebody in the business office than it is for somebody, if, for instance, it was a CRNA and said, you know, well, if we're in a case, it's not like we can evacuate the building. And boy, that's certainly the case. So we had excellent discussions with the different departments on these security scenarios, and have implemented some physical securities and upgrades, and will continue to do that, especially in the clinical areas, to make sure that the folks that are unable to evacuate because they are tending to patients are able to remain in place and shelter safely. So that's been extremely valuable as well. Having some real life discussions. And then it's been just recently, once we got all of our new policies and procedures in place, we had our discussions with the sheriff who oversees the jail, that we finally again begin to accept inmates for treatment for other than emergent services. And we still are not accepting them for elective services as we were before. And as well, we set up a room specifically for treating inmates with bars that handcuffs can be attached to make sure the inmates are contained at all times. And they now will enter not through the main entrance or through the south wing entrance. It's through a much more obscure entrance in the back of the facility that goes immediately into that room that we're going to use for treatment. those are the measures that we've gone through. Those are the processes that we've gone through. Like you say, it'll really never be the same as it was previously. But so far, so good. We haven't had issues with inmates or custody patients, and people are feeling a little bit better now, knowing after we had gone so long without seeing those patients, now they know when they do see those patients in the facility that we are doing everything in our power, as are the sheriff and city police, to make sure that we keep people in our facility safe from those patients, and yet still provide them with the health care services that they need. Next slide, Helen. So this is just a list of some of our policies and procedures that we have rehashed, upgraded, improved, or created from scratch to make sure, as I said, that we are providing the health care to these inmates and custody patients that they deserve, yet keeping our staff as safe as possible. And the next slide, please. I think, yes, that's it. So I am happy to answer any questions that anyone may have relating to this incident and the follow-up in particular, if anybody has any.
Thanks so much, Dirk. Just to start us off here, thank you so much for sharing. It's very difficult to hear your story on this end. So I just wanted to thank you so much. I know it's so important that you shared. Many of our audience at Convergence Health are critical access and rural hospitals. So we just really appreciate you sharing your lessons learned and details about sort of what you went through at Francis Deaconess. So we did have a couple of questions come through to start off. We can start with that, but just want to let everybody in the audience know, welcome to use the chat or unmute yourself and ask Dirk a question directly. But to start us off, we have a question from Lori Gert, who asks, what does fortify mean when referencing emergency department nursing station and entrances?
Okay, so our standard method pre-COVID was our emergency entrance to the facility was never locked. Patients, public, anybody could come in 24/7 and get inside our facility. We locked an inner set of vestibule doors with COVID, and the nursing staff appreciated it so much that we now have a automated system where we can talk with the folks and we can open, the ward clerks can open the door when they come. So we no longer have that unlocked access into the facility. We recently remodeled, I guess I say recently, in 2019, remodeled our nurses station, which is immediately inside that emergency entrance, but it has standard glass, windows that slide so that they can register patients and talk with patients and visitors. We are adding doors to that space, and we are going to add some resistant glass so that folks inside that nurses station will be able to use that area as a refuge for protection against even up to gunshots for a short period of time, which should allow them time to evacuate the area. But the biggest change is going to be that bullet resistant and shatter resistant glass, and adding an extra door that doesn't exist now to keep that area secure.
Thanks, Dirk. Lori, did that answer your question?
It sure did. Thank you.
Dirk, we had another question from Kim on the team. She said, if you had a friend who had just started a new position as the director of facility services at another hospital, what would be your best advice to them as it relates to prevention and response to a violent incident?
I guess for for prevention, it's in this instance, I guess, I mean, there's the whole world of possibilities out there, but as it relates to this and the treatment of inmates and custody patients, absolutely do not assume that law enforcement policies and procedures are adequate to keep people in your facility safe, because we had done that. We have been seeing these custody patients for, as long as I've been here, and certainly even before that. And sometimes you would see them with handcuffs and shackles, sometimes just handcuffs. But in the back of my mind, I always assumed that law enforcement had things under control and that their policies and procedures and our policies and procedures were adequate, and really learned that that is not the case at all. And then just generally for the well-being of the employees of the facility, have the conversations with people. Make sure that you give them opportunities to express their safety and security concerns. And that certainly doesn't mean that you're going to act on every recommendation that everyone in the facility has to make them feel safe and secure. It is a difficult process to pare these down and say, these are measures we're going to act on, and these measures we don't feel we need to act on. But it definitely makes people, they're appreciative, and it makes them feel better to know that you are taking their concerns into account and acting on those that are general safety and security concerns.
A really great point. And I think that ties in nicely with what you were saying earlier about the importance of communicating with the organization about information as soon as possible. Just really, making sure the channels of communication are open with your staff.
Yes, you can never over communicate.
We have a comment from Jenny Winkler, who says, thanks for sharing your experience. There's so many variables to consider in incident response, and appreciate you sharing your organization's approach. Are there any more questions?
and we did get a lot of experience with that follow-up, with the Joint Commission in particular, and it's very valuable going forward. Hopefully we don't have any more of these kind of incidents, but it was certainly, that was a worthwhile process for sure.
Right, and you mentioned that the Joint Commission process was fairly streamlined compared to how you thought it might be or how it could have gone. So that's good to know for all of us. It sounds like it was a very valuable experience.
Yes, that's another thing, a point to make. Don't be afraid to report these things if you are Joint Commission accredited or whatever accrediting body you use. If they have within their program something similar to the Sentinel event, and there's a requirement to report it, but don't be afraid to do that. I mean, be proactive, report it. It was not an enjoyable process at all, but the Joint Commission certainly had a very friendly process for doing that.
Well, we're coming to the end of our time here today. I just wanted to thank you so much, Dirk, for sharing your experience with us today. Such a gift to be able to speak from your perspective as someone who's walked through this experience and has, a great perspective, and that you've learned quite a bit and made changes, and you're able to share this with other people. So I just want to thank you so much on behalf of everybody here today. Thank you for joining us.
You're welcome.
And as I mentioned, this is our final session of our series, workforce well-being and violence prevention. So on behalf of Convergence Health, thank you all of you for coming and joining with us as we've learned quite a bit on this series. We invite you to stay connected with us in the future. If you're not already, join our QI Quality Improvement listserv. And that's where you can keep in best touch with us at Convergence Health. And we share all of our learning opportunities and ways to engage You're welcome to visit our website, convergencehealth.org, to learn more about us. And we have an evaluation survey for this series. When you sign off, it'll pop up automatically. So we hope that you'll take time to complete that. It really helps us plan for future programming, and it'll only take a minute or two. And you're welcome to email me directly if you'd like to learn more, or if you have any questions or want to follow up on anything that you've learned throughout this series, or anything else that Convergence Health might help you out with. So thank you, everybody, for your time today. This has been a wonderful series, and we just really appreciate having all of you with us. So with that, I'll say have a great rest of your day, everybody. Thank you very much.